My name is Claire. I am the research lead at Mindset Health, and I am really grateful to have Dr. Adam Rinde with us here today. Dr. Rinde is a naturopathic physician who has been practicing in the Seattle area since 2006. His practice is called Sound Integrative Health and focuses on digestive, metabolic, and autoimmune conditions. Dr. Rinde lectures and speaks nationally on digestive health topics and also hosts an awesome podcast that I recommend you check out called The One Thing Podcast. And Dr. Rinde is going to speak to us about digestive health and the polyvagal theory. Couple quick housekeeping things before I hand it over to Dr. Rinde. The chat, which I love seeing everyone introduce themselves in the chat. Feel free to continue to communicate within the chat. And if you have any questions for the Q&A at the end, please submit those through the Q&A box, not the chat. We'll be referencing the Q&A box for that Q&A at the end of the webinar today. And then look out for a follow-up email for CE and self-directed CE credit after this. We'll send the recording out and information on collecting credit for today as well. So without further ado, I will hand it over to you and you can take it away. Thank you so much.
Thank you, Claire, for inviting me to speak. I am delighted to be here, and thank you to all of you who are attending this discussion today. As the topic is outlined, we're going to be speaking about the polyvagal theory and how it relates to overall health, and also a little more of an emphasis on digestive health. And I think you'll see that those of you who have been using the Nerva app with your patients, you'll see a lot of overlap between these two worlds, and will help us further understand this connection between the brain and the gut and the entire nervous system, and how it affects the IBS patient and the functional digestive disease population. So without further ado, I'm just going to do a quick outline of the things that we're going to be going through today. And with this being said, this is the general construct, and at the end we'll try to leave some time for Q&A. I expect the talk to go a little bit over an hour. We're going to talk at first about the autonomic nervous system and review some basic science concepts, because the foundation of understanding in the polyvagal theory is assisted by having some basic science background. And then we're going to go into the core concepts of the polyvagal theory as a general overview, and then we'll go into details about each of the concepts as the talk goes on. We'll speak about measurements of the polyvagal theory, how the polyvagal symptoms or polyvagal theory presents clinically. We'll discuss how these theories might apply to the IBS patient. We'll discuss tools of working with patients using the polyvagal theory concepts. And that's pretty much what we're going to go through today. It's a lot to cover this topic in just an hour. However, this is really designed to give an introduction and further your interest and further your understanding of the polyvagal theory. So the polyvagal theory next, I'm going to talk about my qualifications to give the discussion. So as Claire introduced me already, I'm just going to highlight a few other things. I've spoken throughout my profession, mainly on IBS, IBD, dysbiosis, SIBO, a little bit on the aryl hydrocarbon receptor, and I speak a lot about digestive issues. I also am trained in the Sound Safe protocol through Unite, and this is a protocol that uses the polyvagal theory and in implementing it clinically. I don't have any affiliations with any companies. I'm, as I mentioned, an SSP provider, but I do not receive any compensation from Unite, who is the uh, educator of the Safe Sound Protocol and the certification agency of the Safe Sound Protocol. I am a Nerva app provider, recommend Nerva to pretty much all my patients. So let's get started. First, I'd like to start off with what I call, how did we get here? And this particular slide talks about from the trash can to the Vegas. What could I possibly mean by this? So when I was a clinician in the teaching clinic at Bastyr University back in the early 2000s, we were seeing patients, and what we would do is step out of the room and the group of students would discuss what the patient is presenting with, and the resident or the attending would quiz us as to what we think is going on with the patient and ask us questions. And I remember this particular day, I had prepared for that shift and studied the chart of the patient we were about to see, and we saw the patient, took a history, and stepped out of the room, and the resident said to me, "So what do you think this patient has? What's the condition?" And I said, "I think the patient has IBS." And the clinician waved his hand at me and said, "That's a trash can diagnosis. Who else has some other ideas?" And so what came up next with this particular conversation was what was popular at the time. And the student clinician said, "I think it's Candida." And so the resident agreed. We ended up treating the patient for Candida. And sure enough, the patient did feel better with herbal antimicrobials, some gut lining support, some slight modification to their diet, and some stress management activities. So it wasn't IBS to this provider. However, this component of IBS, dysbiosis, was treated. So I've seen this kind of trend of IBS becoming more of a understanding of a construct of various things that are contributing to it, versus being waved off as a trash can diagnosis or waste bucket diagnosis. So throughout the years, since I've been working in this field, there was a phase where we blamed this similar presentation on food sensitivities. And so everybody was being put on elimination diets, and some people felt better, some people didn't. Then further on, the word visceral hypersensitivity came into play. And so we were working on amino acid therapy with patients and helping with their nervous system, working on stress management. And some people in that subset felt a little bit better and some didn't. Then came along really a big phase of dysbiosis work, thanks to Dr. Pimentel's work. And we started treating SIBO, EMO, CFO, and something I'm calling H2SO, which is hydrogen sulfide overgrowth. And all these overgrowths seem to be a contributing factor. And so the whole world for a while was focused on calling this SIBO or one of these subsets. And recently we moved into a histamine era where everything's based on histamine intolerance and MCAS and various other components that may be contributing to this patient population. And finally, we arrived at a new definition where IBS and functional digestive disorders are put into a category of diseases of gut-brain interactions. Okay, so now we're tying all this together and realizing this whole body of pathophysiology that we need to think about in these patients. And so no longer are we at a place where we're calling it one thing. We're actually looking at these patients from a very complex scenario. So let's talk about our patient. And this is a picture of a school bus being covered by a kudza vine. And I was inspired by this picture by one of my colleagues, Dr. Amy Pearl. And we talk about this as being a lot of the patients that we see in complex chronic illness, and how the unwinding of this invasiveness of these various pathophysiology presentations is often what we are focused on. And instead of looking at sort of one area, we're often trying to find like what's the thread, what do we need to unwind. And what I'd like you to hold in your image is that the kudza vine is almost like the nervous system, kind of it's playing a role in almost all of the IBS underpinnings. And so the nervous system is intertwined with the IBS patient. And we will see as we go into the presentation how that relates to the polyvagal theory. So let's get into talking about what is the polyvagal theory. So just as a brief introduction, the person behind the polyvagal theory is Dr. Stephen Porges, who should really be given this talk. However, he's really done a great job educating and written a number of books and publications and provides training for providers. And it's, his work is real, his teachings have really helped us understand the polyvagal theory. But he started talking about it back in 1994. His work involving the polyvagal theory was related to observations made in the neonatal unit with premature infants, and looking at their breathing and heart rate response, something called respiratory sinus arrhythmia. This particular marker is used a lot in research to determine regulation of the autonomic nervous system. We commonly use something related to this called heart rate variability as another marker of vagal tone and the autonomic nervous system function. So he was making observations in various premature infants and looking at other aspects of engagement with the mother and its effect on RSA, some of these early days in the neonatal unit, and watching this function, and then started applying some of those observations towards an understanding of the greater autonomic nervous system and how it responds to threat or stress or danger in the environment from a standpoint of something happening physiologically in our internal environment and our external environment. So really, he's become a pioneer in a field called psychophysiology. And you'll see that this theory has a lot of roots in phylogenetic development, meaning looking at how mammals have adapted over time to develop a nervous system. And we'll go into a lot of that in today's talk. So in summary, on this introduction, the polyvagal theory is a theory that looks at how the autonomic nervous system relates to physiology and behavior, and identifies neurologic pathways, mainly involving the vagus nerve, that are involved with this regulatory process. And it's also informed by changes that were seen in vertebrates as we eventually became mammals and developed into social beings. This is some big picture principles of the polyvagal theory, and we're going to go into each one of these in detail. The polyvagal theory stands on the principle that the autonomic nervous system is a regulator or neuromodulator of the nervous system. It plays a role in assessing for danger and safety, both within the organs and within the environment, and a lot of our behaviors and function is shaped by that. It also talks about something called autonomic hierarchy, meaning that our nervous system developed in a specific order, which we'll speak about, and based on threat, we will default into different components of our nervous system based on when that portion of the nervous system, specifically the autonomic nervous system branches, developed. We will default into certain components of this nervous system based on level of threat and level of safety. It also talks about the development of the social engagement system, which allowed us to bond with humans, and if an environment was safe, allowed for bonding and cooperation and connection that really formed the basis of forming society, families, partnerships, and trusting relationships. And then one of the other components that we'll speak about is the neuroception. And this is sort of the software behind the polyvagal theory. This is our subconscious software that picks up on levels of danger or safety in an environment. So knowing that there is a subconscious software running behind the scenes is a very unique aspect of neuroception, of the polyvagal theory. So we will go into details as to exactly what neuroception is and how that plays a role in the polyvagal theory. This polyvagal theory model was a divergence in psychophysiology in a way. The Descartes model looks at psychology more from the standpoint is, I think, therefore I am. So this was like the classic cognitive behavioral model, and that if we can only control our thoughts, then our behavior and our physiology would fall in line. However, the polyvagal theory identifies that I am, therefore I think. So this is a really pioneering way to look at psychology, is how our body feels and how our physiology is running influences how we think and behave. This is very freeing to someone who has been told that they're just not doing it right, or they're just not thinking in the right way, or their thoughts are controlling their body. This identifies that there is major influence of the nervous system from a bottom-up perspective. So let's take a look at the autonomic nervous system. What a fascinating system of the body. I could not spend enough time learning about the autonomic nervous system. So traditionally, we think of the autonomic nervous system as sort of an off-on arrangement. So the sympathetic nervous system is an agonist to many different organ functions downstream, and the parasympathetic nervous system is an antagonist. So there's sort of this vasodilation to vasoconstriction relationship, or various things like we will say like rest and digest versus constriction, or these sort of off-on relationships, which is largely true. However, in conditions and dysfunctions like dysautonomia, this isn't so straightforward. We'll kind of see the nervous system not operating in this really nice off-on arrangement. So I look at the autonomic nervous system as the body's remote control. Think of descending and ascending pathways, feedback coming from the organs to the brain, and the brain sending down motor activity to respond to that feedback. The polyvagal theory sees it as the autonomic nervous system as a regulator of threat and a regulator of safety. And this is both internal from organs and then also external. And before I move on to the next slide, I just want to identify that it's sort of like a remote control for the body. There's feedback from miles and miles and miles away, and the central nervous system is making remote decisions. So think of it like if someone's doing working from home and the corporation's based in another country, there's feedback being told what's needed, what resources are needed, what support's needed from remote. That works really well in a very healthy organism, normal organism, and it's very efficient. However, we'll see that this command control relies on text messages, which I would call like mediators from the local environment. So if the local environment, like in this picture, we're looking at a blood vessel, has an infection or an inflammation or other components that need the remote controller to act upon, it's sending signals locally and sending these signals centrally. So in a healthy environment, for example, if there is nitric oxide being released in the endothelial tissue, then the central controller might get a signal to send down vasoconstrictive sympathetic signaling, and the environment stabilized, blood flow is stabilized. However, in dysautonomia and some components of polyvagal theory, this kind of local versus command control arrangement might be thrown off by various disorders, by presence of chronic disorders that are not getting better and no longer responding. Then there's this other component called the enteric nervous system, and everybody knows about this as the second brain. And this is essentially fed by the autonomic nervous system, and is, you could say, it's part of the autonomic nervous system. The vagal nerve system interacts with the enteric nervous system. It's also responsible for local signaling. In fact, if the vagus nerve was taken out of the body, the enteric nervous system could still run. So it has its own second brain and is intimately involved with any digestive disorder we speak about, and is sort of the frontier of a lot of things we're learning about the microbiome and how it interacts with the gut, and also how brain conditions, depression, anxiety are related to the enteric nervous system. These are all very much a big part of the research. So it's important to know that all of this is sort of under the envelope of what we think about with polyvagal theory. So one of the things that makes the polyvagal theory unique is that it really looks at the beginning of the autonomic nervous system in the human happened at a certain point where the reptiles and the mammals diverged. What took place, and some think this took place 200 million years ago, is that we actually developed the inner ear bones that made up our sense of hearing. And along the same time, there is thinking that there were two branches of the vagus nerve formed. There was already a dorsal branch. However, at this point, there was there's belief that a ventral branch was formed, which we'll see was the beginning of the social engagement system. This was a key point in the development of mammals as we are today in our ability to have social engagement. We had a shared ancestor with reptiles at one point called a synapsid, which was a mammal-like creature, and it had some of these features that we started to see develop. And at some point, the mammals, the vertebrates, split off into these categories where mammals, as we are today, and reptiles had these differences in the ear bones. Also, in the jaw bones was a big thing that was pointed out at this juncture. So from this standpoint, the phylogenetic standpoint, we have 500 million years ago, it's thought that the dorsal vagal nervous system appeared. And when this is under threat, this was immobilized, disconnected, and organisms under threat would protect by disappearing. And 400 million years ago, not years ago, 400 million years ago, when activated, a sympathetic nervous system developed. And when activated, this particular system responds to flight or fight. And so, as you know, we have now a dorsal vagal system and a sympathetic nervous system. But what's unique to the polyvagal theory is that it really highlights the development of the parasympathetic ventral vagal system, which, as I mentioned, developed 200 million years ago. And when that is activated, there is a feeling of safety and connection, health, growth, and it's restorative. So this protection is in this system is done through social engagement and something called non-threat immobilization. That's kind of like a deep restorative rest. That's not due to threat. Again, we're going to be going into details of all these. So I just want to take a little break here and say, this is the synapsid dimetrodon, which this is reportedly our mammal relative. And I just had to comment on, if this was my grandma, I would really comment on what a lovely smile she has in this picture. So it's hard to imagine, hard to believe, but from a standpoint of our ancestry, and this is the mammal-like dimetrodon that had the development of the ear bones and the jaw structure that allowed us to begin social engagement and responding to sound and various other things that we'll talk about. So let's break down some key differences between the ventral vagal and dorsal vagal complex. So the ventral vagal, which was this newer development, developed from the nucleus ambiguous of the brainstem. And this is really important to remember. It's responsible for vagal activity above the diaphragm. And this is a myelinated part of the vagus nerve. And that was something that did not appear before 200 million years ago. And it regulates the muscles of the face and head, including the eyes, and also involved with those that are involved with sound and lungs and some cardioinhibitory functions. It makes up the social engagement system. And then the dorsal vagal complex. This was the primitive part of the vagus nerve. And really important to realize that this is not myelinated and it affects organs below the diaphragm. So this would be, obviously the digestive tract, because this is the focus of this presentation, would be really involved with dorsal vagal balance or imbalance. And so if we're going to hypothesize what might be out of order with IBS populations, it could be related to dorsal vagal overactivity or disruption. The social engagement system, which came out of the ventral vagal complex, fostered what's called a face-heart connection. So the nerves from this branch, as I mentioned, affect organs above the diaphragm. And these nerves allow us to make expressions, to hear the sounds of safe voices, to connect with others through our facial expressions, through listening, and it fostered affiliative behaviors. And so you can see in polyvagal work, they call this the heart-face connection, is when the heart is connected with the face, someone is in ventral vagal state and more of in a kind of receptive bonding state. I'm going to highlight next neuroception. This is one of my favorite slides because it explains so much of what's going on with a number of our components of the nervous system. And it's sort of a tower that's receiving signals and sending out signals. And neuroception is different than intuition, different than interoception, and it's running without our thoughts. It's a subconscious ability to assess risk and safety. And so it detects various visceral signals, environmental features, dangerous sounding voices, dangerous faces, body language, without us even thinking, will signal the autonomic nervous system. Thank goodness that we have this. The problem is when this becomes faulty and due to past traumas or other reasons, that we'll see that the neuroception is not working as well as a reliable feedback device. And so people can be stuck in a chronic defensive state or a chronic activated state, and their neuroception might be picking up on signals that are imprinted versus happening in front of them. So the interesting thing about neuroception is it sends signals to our autonomic nervous system, which sends signals to the brain, which allows for us to have behavioral responses or organ responses as such. Let's talk about how we will apply the polyvagal theory. And this is applied to so many people that we see. I just want to ask you, I wish I could ask you, and maybe we'll talk about this. Do you ever really see someone that just has IBS by itself? Sure. Like in the beginning of your career, you might just see sort of a more straightforward IBS case, and you get them on their feet and doing much better. But as you get more seasoned in your career, you'll start to see that it's part of a bucket of things that seem to run together. And that's why it's now has a redefined category of illness, because it's layers of life things that seems to travel with the IBS patient. Sleep problems, anxiety, trauma, depression, and various other subsets like fibromyalgia and chronic bladder disorders. It's all intertwined. So when you think about that, the autonomic nervous system is the common thread, along with all the other things that we're balancing. The autonomic nervous system is sort of sensing the danger or safety of this patient internally and externally. So I've put up the slide of the spoon theory, and I think this is a really good way to contextualize all that we do with our chronically ill patients is the spoon theory. If you haven't read about it or heard about it, please look it up. It's very valuable as a communication tool, especially in people who have a really tough time describing how they're doing. But the more spoons you have, the better you feel on a given day. And so a lot of people in chronic illness are dealing with 1, 2, or 3 spoons on any given day. And by learning about their nervous system and how to run it better through applications of the polyvagal theory, all of a sudden you're seeing that they're living a life of 5 or 6 spoons, which allows them to do the deeper work of some of these protocols and treatments and following their hypnotherapy plans and other things that they're trying to do to get better. So we're trying to create energy, create mental health, mental wellness, so that we can help people get further along their journey. So there's many modalities for applying the polyvagal theory. I will talk about these in detail later. However, you should know that between hypnotherapy, which you're already doing, you're already off to a really good start of addressing this region. And one of the things that's also being shown in the research is just using vagal nerve stimulation through some of these transcutaneous vagal nerve stimulators. It's really important to learn how to do them properly, because the access to the vagus nerve is really specific in specific regions of the ear. And that is a really helpful modality, but also realizing that not all patients are ready for stronger treatments, and there's other therapies that might be better for particular patients when you start intervening with their vagus nerve and autonomic nervous system. So here's a list of a few of them, and we'll go into more later. So every vagus nerve talk that I've been to in my life always has some cheesy, somewhat inappropriate joke about Las Vegas. And I told myself I wasn't going to do that on this talk. But I changed my mind, and it's not really a joke, but I just wanted to share. This is me at 21 in Las Vegas with some of my best friends, just looking like we're up to no good or not doing anything really, just having a nice time. But yes, this is the connection that most people make with the vagus nerve. But this also is really great because 3 of the people in this picture, even though it was 30 plus years ago, maybe, are still very much in my life and very much part of my social engagement system that I think about when I'm wanting to connect and feel safe with others. So we're going to go into more detail about the vagus nerve here. And a couple of things that you should know about it is, if you're studying how the polyvagal theory works, you should know there's some key points of emphasis. So the nucleus tractus solarius, the dorsal motor nucleus, and the nucleus ambiguus, these are the key centers where a lot of the feedback runs from our vagal branch. And these are part of the brainstem, and they have ascending and descending signals. You should know that the vagus nerve, most people don't know this, is 80% or more afferent and only 20% efferent. And that means that there's a lot of signals coming up, and then, as we'll see later, sending signals to the brain. And afferent pathways run through the nucleus tractus solarius, and efferents run through the dorsal motor nucleus. And so this is where we got a lot of our kind of understanding of dorsal vagal nerve versus ventral vagal nerve, and how these particular regions lead to certain responses in the brain. And the ventral vagal complex is considered cardio inhibitory, It also regulates breathing and lung function through bronchi, and as mentioned, the face muscles and eyes in control of the face and head. Here's some highlights of some specific regions. One is called the superior jugular ganglia, which is provides general sensation feedback from the body, and the inferior ganglia, which provides visceral and special sensation and coordinates relaying that information to the brain. So all of these particular signalings come up through the vagus nerve and send signals to the nucleus tractus singuli in the brain and something called the poststrema, which if you follow any pain research and other research of central pain, you'll know that these are key regions that are involved with that. Once the signals are in the brainstem, then they will send other signals to other areas of the brain, such as like the amygdala and the hippocampus, for interpretation. So danger signals may send signals to the amygdala, and also hippocampal signals to send down stress responses. So this feedback is constantly coming into the brainstem and then pushing to higher brain centers, which sends further signals down to create action. The branchial motor branch is the branch that comes off the ventral vagal complex that has to do with innervation of the cricothyroid muscle. So this is involved with the regions of the throat and sensory to the pharynx. And so that's involved with swallowing and sound, making sound with your voice. And then the motor branch of the vagus leaves the dorsal vagal complex and has a left and right branch. And it comes down and supplies pretty much most organs, all organs of the body, most of the colon except for the last sigmoid region. And it's involved with motor function or motor activity and sympathetic related and constriction related activities. And in the colon, it also is involved with obviously motor activity in that region and small intestine as well. So it is to note that the last part of the colon is not supplied by the vagus nerve, it's supplied by the splanchnic nerve. Then we also have general sensory afferents that send signals from various fibers in the body, cervical, thoracic, abdominal fibers, to the brain. And these are all relayed through the nodose ganglia and the nucleus tractus. So why am I pointing this out is because the body is doing internal surveillance through the vagus nerve, sending this to the brain. So if you have imbalances in these areas, the vagus nerve is largely involved with interpreting whether or not there is need for action, such as need for making a bowel movement, or need for vomiting, or need for slowing digestion or increasing digestion. There's much activity between these areas. Bear with me on this. I know it's a lot of science stuff, but you'll see that this will help connect the dots as we conclude. As the signals get to the brain, as I mentioned, there's cross signaling from the brainstem up to higher brain centers. We can see signaling from this feedback to the amygdala, which obviously is really involved with the stress response, and locus coeruleus in various regions that help determine whether we're going to have flight or flight responses, connection or safety responses, or shutdown responses. Vagus nerve also is involved with certain special sensory feedback from the epiglottis and taste buds. And then most relevant to our talk is that there is a way of intervening or interacting with this system through the vagus nerve's auricular branch that is part of what comes through the ear and through the tympanic membrane. And so these afferent signals actually get into providing feedback to the vagus nerve system. And so this particular purple region right here, which is called the conchae, cavum conchae, and part of the tragus is usually what's thought of as being input for the vagus nerve. And a lot of the vagal nerve stim devices work off this feedback system. So you can see the vagus nerve is connected everywhere. Here's the various superior ganglia that we talked about and the inferior ganglia right here, and how there's two distinct branches. One of the branches is responsible for the supradiaphragm region, and one of the other branches, which is the dorsal branch, is responsible for the subdiaphragmatic regions of the vagus nerve. We know there's interactions between the vagus nerve and other symptoms, and I'm just going to briefly touch upon this, that the vagus nerve is now thought of as a receptor for the immune system. So there is thinking that there's actually receptors of for IL-1 beta on the vagus nerve that could be triggered by LPS. We all know what that is, lipopolysaccharide. We'll see that in dysbiosis patients. And this is showing us that with infection in other components, intestinal permeability, dysbiosis, that the vagus nerve could be involved in sending off a stress response to calm and counter that inflammation. So this is showing that the vagus nerve, when binding IL-1 beta receptors, will send signals to the brain and release cortisol. The vagus nerve doesn't release cortisol. The hypothalamus region coordinates the release of cortisol through ACTH and can have a downstream anti-inflammatory response. In fact, there's a whole system that's called vagal CAP, vagal CAP. This is a pathway that's being really studied for working with vagal nerve stim to create an anti-inflammatory response. So we see that when the vagus nerve is activated, it has a modality where it will release eventually acetylcholine, which binds to macrophages at the receptors for ACH, nicotinic ACH receptors, which downregulates macrophage activity. How amazing is this to see that if we have a way of calming macrophage activation in these chronic inflamed patients through the vagus nerve. So I see a lot of my colleagues using vagal nerve stim in autoimmunity, chronic inflammatory disorders, and this is the mechanism that this is described. So finally, just concluding this deep dive into the vagus nerve, is that there's all ways it interfaces with our immune system, with our stress response, with our organ response, and of course, with our threat response. Okay, you made it through some of the hard part of the conversation, and now we're going to get into more specific polyvagal stuff. So Porges described this autonomic hierarchy where the organism has a level 1 through 4 response to threat. And this is a response that was based on development. So we talked about which parts of the nervous system developed in order according to the dorsal, vagal, and sympathetic nervous system. And so level 1 self-regulation is based on when the brain responds to threat from a very kind of basic standpoint. So level 4 is kind of a higher level response. So humans and mammals have the ability to respond to threat with coordination of motor, behavior, emotional tone, and bodily state to negotiate social interactions. And then if pushed, if the threat continues, we'll kind of work our way to more of these other levels, so flight or flight responses, possibly freeze responses, and eventually could be, sort of flight shutdown responses, disappearing. Humans innately, it will come from a standpoint of level 4. Mammals and humans in general will come from a state of level 4. But what we see when the blank hits the fan, we'll see people's real imbalances show. So people who tend to have brain disease and illness will really get inhibited into these other states much easier and much faster. In a healthier state, people can stay in a ventral vagal state in response to threat and try to kind of stays balanced. This term resiliency, can kind of withstand stress or threats without becoming flight or without becoming shut down. So we have to be really sensitive to where our patient is landing on this continuum. So this autonomic hierarchy was first described by Dr. John Jackson, and he calls this the theory of dissolution. And this is something that Porges stands on as one of his key principles of seeing that the higher nervous system tries to inhibit or control the lower part of the nervous system. So the ventral vagal nervous system will always try to inhibit the sympathetic nervous system because it's very costly to go into sympathetic nervous system state. But in illness, this is very difficult, and our response threat becomes more defensive, or we can get chronically struck and not being able to get out of this defensive or danger mode. So this is just more of details about these particular systems. I think it is good to spend a few minutes to look through this. And the dorsal vagal response increases when that's activated, there is avoidance in the face of fear, and increases storage of fuel. I was just speaking with a patient who is in the chronically stuck dorsal state, and they're experiencing some weight gain and kind of sluggishness, and that is usually because this shutdown response is taking place. These patients tend to have more endorphin release to increase the pain threshold. There's a decrease in all these markers shown here: metabolism, blood pressure, heart rate, and a decrease in socializing. And they call this the freeze response. And when the sympathetic nervous system is activated, everybody kind of knows about this, but there is a fight or flight response. There's also one called fawn, which you should know about, which is sort of masking fight or flight response to make nice. And that in this particular state, most people know that this is a very action-oriented state, and things are mobilized, getting people ready to fight or flight. All the things that you would think are mobilized, including metabolism, heart rate, blood pressure, and there's decreased digestion. So a lot of our IBS patients are vacillating between these two states and not just landing nicely in one or the other. The ventral vagal is, as we talked about, sort of this really collectively socially engaged state, and the immune system is increased, the circulation's increased, oxytocin is increased, breathing function's increased, and there's less defensiveness, flow state. You get the deal. A lot of this is just really reviewing what we just talked about. I want to point out that there are blended states. So when someone is in a state of play, they might be mixing ventral and sympathetic. I was thinking like some of the moments of playing basketball with some of my teammates and where things were just really going well and we were connected, communicating, but we were playing at our best, at top performance. That's kind of like a ventral sympathetic blend. And freeze state is when sympathetic and dorsal is kind of combined. People feel passive aggressive, or they feel stuck, or they can't really make up their mind, kind of going back and forth, vacillating. Stillness could be a combination of ventral and dorsal. And this may happen as a positive thing. So say like someone's breastfeeding or just really going into deep rest, they might be combining a sense of safety with the ability to shut down. I've seen this happen when people have been on like a healing journey and they finally are feeling better. They just feel like sleeping, and they're not depressed. They just want to sleep and rest, and that's kind of be still, and that can be a healthy thing. So when you listen to your patients speak, you can hear them signal where they are. If you're getting a lot of I can'ts, that's like a dorsal immobilized state. You're getting a lot of I ams, that's ventral. I am this, I'm feeling this way. If you're getting like I can do this, it's more sympathetic, mobilized. So again, looking at these different levels, this is a really detailed slide. I encourage you guys all to kind of pull this one down from the internet. This is by Sarah Schulte, and also realize she has a really great organization that works with horses related to polyvagal theory, and can see that in safety, we're kind of wanting to land here and live in this state, and a kind of this is a sort of well-being state, and then being able to kind of move into these states when needed, but quickly descend and deactivate and discharge and come back to safety. And dysautonomia is sort of the situation that's happening in polyvagal theory, is that one of these regions is either overreactive or underreactive. So with the supradiaphragmatic reactivity, which you should already know by our conversation, that's ventral. If the ventral complex is underactive, you'll see a lot of issues related to above the diaphragm. If there's an overwhelming subdiaphragmatic reactivity, so someone's stuck more in dorsal, then you'll see more issues below the diaphragm. This is part of a questionnaire that you can download. We'll talk about a tool that you can evaluate someone for this presentation. And this diagram really helps you kind of, when you're sitting with your IBS patients, think about where their possibly imbalance is. Okay, social engagement system. I just want to take a moment, and if I was with you, and if you're watching this as a recording, and you're not driving, and you're not doing something like being on a treadmill watching this, it might be a good time for you to get ventral. And so we can help ourselves when we're generally healthy shift into ventral by doing visualization, much like probably what hypnotherapy is helping people get into a ventral state through these positive imagery and feelings of safety and that wonderful soothing voice that we all love to listen to. And with this is my late son, Jordan, who passed away from cancer. And this was the last picture I took of him before he went into the hospital for the last time. And I just love this picture. And whenever I want to get ventral, I picture this moment when he and I were looking at each other with so much love, and I feel immediately safe and connected, and brings back this feeling of connection and bonding with someone so deeply, which we're so fortunate to have. But these things you can do with your patients, they can help them bond with a pet, or help them a pet that they know, or a person that may be alive or passed away, to help them feel the energy again between them. I can just look at this picture and be brought into the ventral state. And the social engagement system that we were just talking about involves a number of cranial nerves. Cranial nerve 5, 7, 9, 10, and 11. These all coordinate together through that ventral vagal complex. And as we've talked about a number of times, are involved with assessing the environment, sending signals to the brainstem, up to the cortex, and then a response. So one of the key things to realize about this system is it's very involved with the middle ear function. People who have issues related to middle ear function, which is common in the neurodiverse population, it can be connected to polyvagal like imbalances. So this is something to understand, that the control of the middle ear muscles are related to social engagement and related to this ventral vagal complex. The ventral vagal nerve in the social engagement is thought to be related to this relationship between mother and infant, where there's a sense of facial expressions and prosody in the voice, and connection and bonding between mother and infant, suckling and swallowing and bonding through breastfeeding. This was all seen as an early development from this system to create this social engagement. So again, bonding is related to this, and a result of a healthy, functioning social engagement system. The baby responds to positive and safe voices by turning their head and smiling and cooing, and responds to danger by crying or pushing away. And it's a very fine-tuned neuroception system that provides a sense of safety and danger. And this all came out of the ventral vagal complex. This is more of a summary slide, but also just to kind of mention that the eye muscles and the gazing, one of the vagal nerve exercises involves gazing, and how the eyes move, and muscles of facial expression, a real smile versus a pretend smile, how we respond to others, and we're detecting their body language, we're detecting their movements, we're detecting their sense of safety, all through our subconscious, and our brain makes decisions for us along those lines. So when we're feeling safe, all these good things happen. A marker of a depressed vagal social engagement system is something called lack of a vagal break. So this is also associated with low vagal tone. You've heard that term. So in threat, what should happen is with the cortical threat, increased blood pressure, heart rate, increased cardiac output, the vagus nerve should come in and kind of buffer that and inhibit it. But people who have poor vagal brake function will have this kind of on gas pedal response ongoing, and with very little ability to inhibit this. And so we see this with people with like chronic tachycardia and other blood pressure issues that are in sympathetic mode, and they're not able to buffer this. And so a lot of these people will have poor eye contact. Their tone of voice will be monotonous or deep. They'll not listen well. They'll be holding their breath. And if you tested their heart rate variability, they would have low heart rate variability. Thanks for bearing with me. We'll be wrapping up in about 10 minutes for Q&A. So I'm just going to continue talking about these really interesting aspects. One of the things about the vagal brake is that if someone is in the cortical threat state and not able to have a good vagal brake, it's very metabolically demanding. Over time, this just wears people out and the fatigue kicks in. So what we're trying to do with polyvagal therapy is, help the vagal brake work. Neuroception is one of the key foundations of the body's detection of this safety or danger response. And neuroception is derived through feedback to the temporal lobe, and it's based on a subconscious response to various things in our environment, including the facial expressions, biologic movements, and limbs. If anybody's done some study of the PTSD world, you can know how much facial expressions play a role in triggering PTSD. And so this is part of our neuroceptive environment. And this further talks about that, as we've discussed already. The vocalizations, movements, facial expressions, body language goes through a feedback of, is this safe? Yes, then it will kick down to the social engagement system. If it's not safe, a lot of it's like an amygdala response. And these are coordinated through these different regions of the body, higher brain centers that help with determining the output. The nervous system is an input to processor to output system. And so the processor determines if this is safe or not, and does the appropriate response. So these are the three different pathways that we've talked about: safety, danger, shutdown. Neuroception is sending feedback to all these pathways, and they coordinate with different regions of the brain. Danger pathways work through the amygdala and the periaqueductal gray region to send a fight or flight response. And then shutdown pathways also work through a different region of the periaqueductal gray region. And as you can see, this system is not only from the environment, but this is also, keep in mind, 80% of the vagus nerve is efferent signals from the body, sending signals to the brain. So feedback from organs, including the digestive tract. So where does this go wrong? And this is a key thing to realize, is that in a chronically ill patient who may have had like a history of trauma or a history of anxiety, depression, or chronic illness, medical trauma, or other related disorders, anxiety disorders, neurodiversity, they might have what's called a neuroceptive mismatch. So their danger cues outweigh cues of safety, and they're chronically stuck in a story or a response. They are chronically stuck in a disease, and either through their dialogue or through their body's physiology, they're in danger mode. And it's very hard for them to get out of that danger mode. So this is like the chronic IBS patient who has been bounced around to practitioner. And at this point, they're not only dealing with a medical condition, but they're traumatized by the medical condition. And so at this particular standpoint, their subconscious might not be getting an accurate read of what's actually going on in their body. So there needs to be both physical healing and nervous system healing and autonomic nervous system healing with this patient. So we see this, and here's some research studies to back this up. Faulty neuroception in many subpopulations, and including OCD, attachment disorders, PTSD, and that's a lot of times what we're trying to heal. There are some clinically defined dysfunctions of interoception, which is the ability to explain what's going on in your body, and neuroception. So alexithymia is seen in some subsets where people have a difficulty expressing their emotions or perceiving their internal states. You'll say to them, like, can you tell me how you're feeling? And they'll just tell you, I just can't. I hate pain scales. I don't know how to describe what I'm going through. This is seen as defaulty interoception and neuroception, possibly linked to the vagal nerve system, and then something called synesthesia, where one point of sensory information will trigger another modality. So someone will be listening to music and they'll be listening to music and they'll see colors. They'll think of a word and they'll experience taste. These sort of special abilities can be linked to this faulty neuroception or faulty interoception. Okay, applying the polyvagal theory. So as we know that there's a huge link between the functional gastrointestinal disorders and abuse and trauma. If you've never looked up the information on the ACE score, please do. You'll see that there's a large history of neglect, abuse, challenging childhood events in our population of IBS patients. And a lot of patients may have grown up in an environment where it was dangerous or not trustworthy, or they had to lie to themselves to survive or trick themselves to survive, not knowing. They had to trust people that were maybe not trustworthy. And this can kind of be intertwined in this world of gut-brain interactions, and likely through this throwing off the system that we've talked about so much today. There's been some research on heart rate variability in IBS patients, and it's trending towards the fact that IBS patients have lower heart rate variability. So this is kind of a sign of dysautonomia in our population. This is one study I pulled up that discussed it. I'm not going to go into the details too much, but I wanted to highlight that this subset that were measured for heart rate variability showed that it was significantly related. IBS had a significantly lower heart rate variability compared to healthy populations. And then this study did some studies of heart rate variability measurements in women with IBS. And although there wasn't a difference in HRV overnight during sleep between healthy populations and the IBS patients. They did notice that of the IBS patients, that the HRV and sympathetic nervous system imbalance was more in the IBS-D patients compared to other subsets of IBS. And this study is looking at STIM on neurostimulation for the auricular region, as we've talked about, and there was significant reduction in abdominal pain in these IBS patients doing this trial, 30% or more improvement of their abdominal pain. Reduction of more than 30% was found in 59% of the patients who received this treatment versus the sham therapy, which was 26%. So there's a number of kind of clues in this. These are somewhat cherry picked, but the point, there isn't a lot of research out there looking at this aspect, but I wanted to share some of the research I've found. How do you screen your patient for this polyvagal related imbalance or dysautonomia, or however you want to put this into a category? Well, you're all good clinicians, and probably without tools like this, you probably can just see it just based on history and the observations and vitals and other physical exam findings. But if you want to do a questionnaire, this is a really good questionnaire called BPQ-20 ANS. This is put out by a group that Dr. Porges is involved with. And this does a good kind of assessment of autonomic nervous system dysfunction and scores where it might be landing, like in the supradiaphragmatic region or subdiaphragmatic region, to kind of guide your treatment. And then there's also ambulatory HRVs that we should all be doing with our patients in this world. It's really a helpful tool to measure progress. There's some that are done in the clinic, and there's some that ambulatory you can use listed there. There's lots of ways to promote vagal tone, passive and active. How to determine whether a patient is doing passive or active really comes down to your assessment of their energy, their time, their resources, and the research that has been done on these modalities that applies to their particular condition. But I will say that all of the passive therapies, might be looked at and sort of figure out which one your patient is drawn to, and which one they'll comply to, and which one they can afford and have the time to do. And sometimes passive is really good in the subconscious illness, because they don't have to think about it, and the body is receiving this treatment. Sound safe protocol, which is one that I do, would consider part of the passive. This is more of a music type therapy. And then active therapies, you can see here, all really amazing for helping with accessing that ventral vagal. You have to go really slow. One of the things Dr. Porges is really big on is titration. Do not start off with mega doses when you're balancing someone's nervous system. It should be very titrated, especially like things like herbal medicines and adaptogens and gut microbiome balancing. Going slow with this group that has a very disturbed nervous system is really important. And we talked about the auricular vagus nerve modulation. I use this in my practice. There are some units people can get one's called Alpha Stim. That's really good. And then there's specific units that actually are used in research that target the specific areas of the auricular branch. It has to actually stimulate this conchi area, and they should be done one ear at a time. Usually it's recommended to do the left ear only, and very slow doses. Is a very powerful treatment. to stabilize the vagus nerve. This is an example of a yoga technique that involves some amount of deep breathing, breath holding. This is called Kriya Yoga, the specific form of yoga that uses a bellows breath, which is a rapidly inhaled and forcefully exhaled breath. That's like 30 breaths per minute. So it's a very important kind of to learn these unique breathing practices that could be balancing, to realize that some breathing practices will stimulate sympathetic nervous system, others will stimulate parasympathetic nervous system. So to really know what you're doing, I like Oxygen Advantage, which is, I'll put a plug out for them. Concluding thoughts. Thank you for being with me today. This has been a lot of information to cover, but really fun for me. I really like it as we're learning more about how to help our patients, and it all clicks into place if you've been treating IBS patients for as many years as I have, and chronic illness patients like I have as well, how much this autonomic nervous system is sort of our way to mother and heal the body back into balance. And I look at like an attention to communication, to connection and integration. So such an important system to know, such an important system to learn about. You might want to always think about this with your patients who are not getting better. You might want to consider this the first time you meet with a patient, especially if they appear to be complex. It's really important in general to be trauma informed if you're going to work with IBS patients. So, dedication to our patient that's not getting better. Let's continue to try to find threads, unwind, help disentangle the confusion in the body and in their entire system. And most of all, this just shows the importance of human connection and being kind to one another and trying to prevent and reduce trauma for our generations and those are the people that we love and care for and those in our community, because things that happen at a very, very young age or even later in life can have a deep impact on the nervous system. And kindness is always a good golden rule. So with that, I'll leave you with my contact information, the way I process things and the things that I look at. This is where I do everything these days, reading, promoting my videos, my podcasts. There's some other contact information if you'd like to reach out to me. And thanks, and I'll stop sharing the screen and join the group.
Awesome. Thank you so much, Dr. Rinde. That was fantastic. And I know I speak for everyone in the comments as well that it was really a fantastic presentation.
Thank you.
We do have a couple questions, so I'll jump right into those, just being cognizant of everyone's time. The first question I have was actually my question, so it wasn't submitted, but the polyvagal theory is obviously very complex, and we've just scratched the surface of it today, but it's very clear that there's a lot of nuance, a lot of detail to it. At what level do you actually go into with your patients, and how do you decide what level is appropriate?
Well, I have found that it's very easy to explain to patients. There's an innate wisdom about this this scenario that people have turned over in their own heads as they've navigated their own health system. So I basically, the charts that I've shared, like the different hierarchy, that's the starting point we're talking about the different branches and the different behavioral responses. I think that's very easy to understand, and most people I get a lot of kind of wow amazement and sort of feeling of relief of like, wow, this explains me. And it's actually not so challenging. There's a lot of good booklets out there. Like Deb Dana has like a picture booklet that you like have like a flip chart of explaining the concepts to your patients. I would recommend that, depending on your teaching style, if you like using visuals or pictures. It seems to get across pretty clearly with patients.
Awesome. There is a question about submitted by Alina Vitak. The question is, are you aware of any vagal-based approaches to aid patients who struggle with infertility?
So, I mean, infertility has a lot of various root causes, right? So, from a standpoint of HPA-G communication, so HPA acts as to gonadal communication, with patients who clearly have a hypothalamic or adrenal kind of involvement with this scenario, 100%. I mean, calming the nervous system and getting to a place of safety is essential in being in a position for conception. Now, I want to say that very carefully because there's a lot of people who get a message that, well, I have to be perfect to get myself in this perfect place before I'll be able to conceive, and that in itself can create more heightened anxiety. So what I want to say about that is just a little bit of downshift on 1 month might be enough to make things go to conception. So it's like the spoon theory. It's like, well, just a little bit of this mixed into all the other things you're doing, creating a sense where your body feels safe seems to be innately an important aspect of the conception process.
Awesome. Thank you. The next question is, how do you decide on whether patients should receive passive or active vagal tone therapy?
Yeah. Well, personally, I think the shutdown state is clearly someone who needs passive therapies, because it's like I was talking about someone earlier. There's times in your life where I was saying you want to call like Kobe Bryant, rest in peace. Like you would have called him and say, hey, this is not going well, and he would give you like a pep talk and say, well, just go work out, go hit the gym, go do all these other things. There's times if you're shut down that you're not calling that friend because you just are not in a place where you could even dream of having the energy of doing those things, and it would actually make you feel worse. So passive therapy is really come into play for the patient who's really shut down, and they just need someone to provide that support. That's going to be easy for them to do, not too costly, something possibly they can do from home or a short drive, and they can afford, and they just to get to kind of have the therapy brought to them. That's what dorsal is like it's brought to you, versus sympathetics like I'm going for it, and vagal's more like I'm connecting with others, I'm playing, I'm networking, I'm building things with people. So kind of this trend in the United States with pickleball. That's more of a ventral thing.
I'm guilty of being part of that trend.
I need to do that.
The couple questions we have left are more housekeeping questions. So one question around using Nerva specifically with children under 10, and I can certainly answer that. The grade level of the readings in Nerva is to a sixth grade reading level, and so it's the protocol has been validated in 18 years and older, but we're right now working on some research in more pediatric population, but just being aware of the general reading level that the actual education is built for. And then the last question is just around accessing the slides. So we are not going to share the slide deck, but we will share the recording. So if you have to go back and reference anything in the presentation, you'll have access to the recording for that.
And I'm happy to share the PDF of it. I just can't share anything that would be reproduced. But if anybody wants to reach out to me, or I can provide Claire with the PDF.
Awesome. Sounds great. Any concluding thoughts? Otherwise, we can wrap it up.
Yeah, I think it'll be really interesting research-wise. It seems really easy, to me. If there can be ways, I think looking forward to have HRV be tied into some of these modalities as a really good metric. I want HRV to be the fifth vital sign, fourth being menstrual cycle, being added on to, the mix, and fifth being HRV, because it tells us so much. And it'll be really interesting. That's sort of my hope for the future, is that we'll just have a great way to look at someone's HRV and see trends and make some conclusions about their autonomic nervous system and their balance. The other thing is, I just really want to hone in on that all the things that we do for IBS are really important, and this is just sort of part of the milieu, and we need to continue to treat the dysbiosis, the intestinal permeability, the visceral hypersensitivity, and the look at food and the connection there. It's just that we've come so far with this, and it's just really exciting, and lots of promise.
Awesome. Thank you so much. This was
Welcome.
really fantastic, and we're really excited to have you join us and to be able to offer this to healthcare providers.